So my friend Beth McHugh couldn't be here, so I'm substituting. But these are all Beth's slides, apart from this one, just to introduce me. I work at Great Ormond Street in London. It got a lucky mention in the London Olympics opening ceremony. So the treatment-related complications that children will get with cancers are listed there, and they include, in the bottom bits of the slide, just benign pneumatosis, fungal infection, post-transplant LPD, and graft-versus-host disease. But Beth or I want to concentrate on the upper part of the slide, the first four things, because they cause the biggest headaches in general. Typhlitis seemingly was just diagnosed, first of all, in 1970 in children, but that makes sense really, because it was only in the 60s that they started treating children with leukemias with chemotherapy. Typhlitis is a complication of chemotherapy for hematologic and solid malignancies. I don't see it much in AIDS, but I see it a lot in the bone marrow and stem cell transplant patients. The clinical features are neutropenia, abdominal pain, fever, and diarrhea. And the etiology, colonic mucosa is disturbed by chemotherapy, leukemic infiltration, you get bacterial invasion, compromised hosts, and things can go downhill from there. Thankfully, this scenario with a necrotic appendix and necrotic perforated periphery is rare in our experience. Should you do ultrasound or CT? Well, that's the other thing I meant to say in this talk. Here I am, a European, giving an American talk, and I thought when Beth sent me a slide, oh my God, I disagree with lots of her points. But luckily I don't. So, ideally you should do ultrasound first, but there are times when you need to do CT. Beth did a study many years ago showing that ultrasound was far better for predicting the duration of typhlitis, but in the paper it's clear that the CTs were done usually without intravenous and virtually always without oral contrast. So to assess the bowel wall thickening in a child's bowel when you have no IV or oral contrast would be difficult. So CT was poor in that paper, but in general CT is very useful if the child is very sick. Not surprisingly, more segments involved predicted longer duration of typhlitis. And although typhlitis is largely, by definition, is a right colonic or cecal inflammation, you can get a pancolitis. You should always assess it with the addition of colour Doppler ultrasound, and assuming that you have the same colour Doppler settings, you can get mild, moderate or severe ischemia at colour Doppler. You can even get a medical appendicitis that's treatable medically and not surgically in this context. So the take-home points. Ultrasound more accurate predictor of typhlitis severity than CT. It avoids the radiation, which we like to avoid in young children, and of course you can take it to the patient. You can evaluate the entire colon. Colour Doppler is useful. There's a learning curve for everything. And CT is still indicated when there's a surgical abdomen, and occasionally when this ultrasound findings don't correlate with the clinical picture. And I've mentioned that you get a medical appendicitis that's treated medically. So moving on to hepatic veno-occlusive disease, which we should more likely call sinusoidal obstruction syndrome, although we tend to persist with the term hepatic VOD. This is a serious early complication, usually of bone marrow transplantation, or in the first few weeks, but we also see it in the Wilms patients after initial chemotherapy. I don't see it in a thalassemia, and allegedly it can be up to 50% can be the incidence, but that's not in our experience. You get fibrous obliteration of the sinusoids and central veins induced by total body irradiation, which thankfully is rare now for bone marrow transplants, and chemotherapy. The clinical presentation is jaundice, painful hepatomegaly, and fluid retention, and particularly fluid retention. And it's critical to differentiate from graft-versus-host disease, hepatitis, or drug-induced cholestasis, but it's usually easy because they virtually always have ascites, which these other diseases don't typically. The clinical McDonald criteria have an 88.5% positive predictive value, and you develop with 2 or 3 of these findings within 20 days of BMT 2% weight gain, increased liver size or right upper quadrant tenderness, or an increase in the serum bilirubin. And they're very useful. Ultrasound is an occasionally useful tool to confirm the diagnosis and monitor treatment, although it's actually it's probably a little bit better at excluding other diagnoses. And the McDonald criteria are better than ultrasound. Here's a brief anatomy tutorial. It's easy for the pathologist. Blood vessels or veins are blue, arteries are red, and bile ducts are green. That's the sum of my anatomy knowledge. Here's a liver lobule. The central vein is in the center, and you get central vein occlusion in veno-occlusive disease. So this is a paper Beth wrote. Patients with hepatic veno-occlusive disease develop decreased or reversed portal venous flow velocity after bone marrow transplant in a minority. No other single sonographic finding correlated with McDonald criteria. No combination of sonographic findings correlated with the McDonald criteria. But you do get hepatomegaly in some patients, but that's very difficult to assess in children who are of different sizes. And you get gallbladder wall thickening, usually in association with ascites. Here is one child that passed through St. Jude some years ago. Bone marrow transplant for relapsed AML. 4th of August, 6th of August. The Doppler settings are lower here, but you can see obvious portal vein flow on the left-hand image and none on the right-hand side. And this is demonstrating a second slide. And yet, one day after starting Defibrotide, there's resumption of the portal vein flow. And you know what always happens when you give a talk is you only notice something when you're up here with that heightened awareness you have. I've just seen that the colour is red on this slide, and after Defibrotide is blue, and I don't know the answer whether that means it must be, it's reverse flow, but at least there is flow. So the take-home points. It's a clinical diagnosis largely. Ultrasound usually to confirm the diagnosis, monitor therapy, and exclude other diagnoses. Most common ultrasound findings: decreased or reversed portal venous flow, hepatomegaly, gallbladder wall thickening, and ascites. I find ascites very useful. Moving on to asparaginase-associated pancreatitis. ALL is the most common childhood cancer with a 3.5 per 100,000 population diagnosis in children. Survival improved dramatically since the 1960s. The gains of survival largely due to intense, prolonged treatment, often with asparaginase. And acute pancreatitis is serious treatment-related toxicity. And premature cessation of asparaginase in these kids leads to an inferior event-free survival. And this is the only slide of Best that I'm not quite in agreement with, insofar as that 10 to 80% can develop severe pancreatitis, and I'm sure that's true, but I went through our interventional radiology database over the last 20 years, and no child who's had a pseudocyst or pancreatic collection by our interventional radiologist has had an asparagase-induced pancreatitis. There's been other causes of pancreatitis, so perhaps the severity is lessening over time. And the diagnosis requires two of the following. Well, I think it only requires one. I've seen many patients who have no abdominal pain and have a normal pancreas on ultrasound or CT, and yet they have sky-high amylase and lipase, and we have the working diagnosis of a pancreatitis. So the possible complications: hypovolemic and septic shock, renal dysfunction, cavity effusions, respiratory distress, similar in adults, and of course delayed problems will be pancreatic necrosis, and if you get necrosis you can get complicated by infection and multi-organ failure and the problems with pseudocysts. For all children, first-line modality is ultrasound. It may be of limited value due to an ileus and therefore distended bowel loops getting in the way. Suggestive of pancreatitis would be a dilated pancreatic duct, poorly defined pancreatic borders, peripancreatic fluid, and debris or septations, and fluid collections, obviously. So here is a child with AML, possibly a swollen pancreas, although that's a really difficult call in children because the variability in the sizes in the normal pancreas is difficult. But what's definitely abnormal is there was some stranding here in the pancreatic tail. Again, same finding. CT scan the next day clearly shows peripancreatic issues and inflammation. And CT of pancreatitis is more sensitive than ultrasound detecting and grading severity. Better depicts fluid collections, pseudocysts, pancreatic necrosis, pseudoaneurysms, venous thrombosis, parenchymal infarcts, and even fistulas. There is a CT Severity Index used in some pediatric papers, although Beth emailed me and told me they don't really use it much in clinical, individual, everyday practice, but they use it to predict in general for their children. And the severity is a combination of the Balthazar scoring system, which goes up to 4, and the pancreatic necrosis, which is up to 6. So you add the two together, and the maximum score you can get is 10. And if you have a score of 10, then the outlook is not good. So here's a child with I'll carry on. Normal enhancing pancreas and some peripancreatic fluid collections and pelvic and RIF fluid collections. CT score of 4, no necrosis, so that overall total is 4. Another one, CT 4, there's some fluid, but dramatic necrosis, over than 50%, so the total score will be 10, and inevitably that child is likely to have complications. Other complications can be thrombus in the venous system, the SMA or the SMV confluence with the to the splenic vein. Oh, sorry, splenic lesion, and here's thrombus again in this SMV. Take-home points. Asparaginase is the major problem with pancreatitis in the ALL patients. Imaging plays a crucial role. Ultrasound may be misleading and non-diagnostic. CT is more sensitive to complications, which can be life-threatening, and the severity scores may be useful too. So it's CT is useful. Our approach would generally be we would do ultrasound in the children who are moderately sick, and if the ultrasound isn't very abnormal, we would have a low threshold for MRI. But in the sicker children, we'd go immediately to CT, because it's quicker in that situation. And the final thing I need to talk about is hemorrhagic cystitis, which is a significant cause of morbidity after stem cell transplant. Up to 20% of patients. The cause of lesions are all listed here, all of these, but the major ones are myeloablative conditioning, radiation, cyclophosphamide, and BK virus. Patients presented with hematuria, dysuria, bladder spasm, and that can occur despite being given mesna and hyperhydration as protective measures beforehand. When protective measures fail, the clots inhibit contraction of the detrusor muscle, so the children continue to bleed. You can put in saline irrigation. If the disease is focal, cauterization can work, although I haven't seen that work very often. If disease is diffuse, evacuate the clot, intravesical sclerotherapy, or in severe cases, urinary diversion, internal iliac artery embolization, ligation, cystectomy. And this can be very severe. We often have to resort to embolization or cystectomy in these situations, which is quite invasive and problematic. So you get loss of hyperemia, bladder wall telangiectasia, dramatic bladder wall thickening and hypervascularity. And very quickly, the hypervascularity can slough off to a huge thrombus. That's a big clot within the bladder or lumen. The upper tracts can get affected too, both with hydronephrosis and debris. Now this is an old slide in relation to an old paper, and we wouldn't now be doing cystograms looking for reflux in the vast majority case. There would have to be a very definite indication for that. You get urothelial thickening and debris in the upper tracts, so it's important to also assess the upper tracts. You can do a thorough diagnostic evaluation. So the take-home points. It's a major complication of bone marrow transplants. Viruses, cyclophosphamide, and radiation contribute in particular to the development. Once the clot develops, it can be very difficult to treat because the treatment involves flushing the bladder, and of course that irritates things further. Ultrasound is pivotal to diagnosis and monitoring. Color Doppler is useful. always remember to check the kidneys too. So my take-home points from Beth's lecture. Abdominal complications of cancer therapy have characteristic presentations. We radiologists play a pivotal role in diagnosis and follow-up. Most complications are managed medically, thankfully, but require a lot of input from radiologists, and ultrasound should be the first line imaging. Thank you very much.